Hi, I'm Dr. Edward Fisher from New York University School of Medicine, and it's a pleasure for me to discuss triglycerides with Dr. Karin Bornfeldt, a professor at the University of Washington in Seattle. We've had a lot of talks at this meeting on triglycerides. In fact, Dr. Bornfeldt was the very first speaker of the entire meeting in a hot topic session. And what's interesting to me, and we'll hear more why it's a hot topic, is that triglycerides have had a checkered history in preventive cardiology. And now by types of research that I'll let Dr. Bornfeldt discuss, we have a much more nuanced appreciation and see now more direct connections between triglycerides and cardiovascular disease. So again, we had this great talk to start off the whole conference. And if you can just tell us a little bit about the, we'll say the distillation of your talk for the audience.
Yes, I'd be happy to. So we're very interested in how triglycerides might contribute to residual cardiovascular disease risk, especially in people with diabetes, either type 1 or type 2 diabetes. And also the proteins that regulate the triglyceride-rich lipoprotein particles, or TRLs. And we've been especially there interested in apolipoprotein C3, which we and others have shown can predict incident CVD risk in people with type 1 diabetes. And so how does this work? We're very interested in whether it's a biomarker and also a mediator. And our mouse models of diabetes accelerated atherosclerosis have shown that it is actually a mediator of diabetes accelerated atherosclerosis. So if you silence ApoC3 in a mouse model, you can prevent atherosclerosis in those diabetic mice, even though they remain severely hyperglycemic. So silencing ApoC3 lowers these triglyceride-rich lipoproteins. So we're interested in the mechanisms whereby this happens, and using transcriptomic analysis of mouse lesioned aortas, we have shown that silencing ApoC3 in the liver can prevent a majority of the signatures we see in the arterial wall, suggesting that these triglyceride-rich lipoproteins contribute importantly to atherosclerosis in diabetes, at least in the mouse models that we
So you keep mentioning mouse models, and I do a lot of mouse model research as well as many people here. And I remember one of my colleagues said, introduced himself as MD, mouse doctor. And of course, we're not trying to be heroes in the mouse health community by curing their heart disease. But like many things, ApoC3 has gotten a lot of attention because of an experiment, what we call, I guess, an experiment of nature. I guess it was around 2007 or 8, as Dr. Bornfeldt knows, but just so the audience knows, there was a paper in Science that showed that people with a null mutation in ApoC3 not only had lower triglycerides, but were protected from cardiovascular disease. And so this really catalyzed a lot of interest, because ApoC3 was known as a protein for a long time. The apoproteins were purified and then sequenced at the protein level and the DNA level, you know, whatever, in the 80s. And so it was interesting. Some people studied it, including me, in the 90s in a mouse model with Professor Jan Breslow. But that paper, wouldn't you say that paper really got a lot of attention now on what C3 is doing?
It certainly did. And I think it's very important to start from the human perspective, right? So we like to use something we call a human first approach, or bedside to bench approach, where we search for biomarkers in humans and then use the mouse models just to reveal mechanistic insight.
Right, that's very important to particularly for maybe the pure clinicians in the audience, is that the mouse models allow us to do mechanistic research, but we always keep going back and forth. So some people would say bedside to bench and back again, because there's this interaction between the fundamental discoveries and of course the clinical situation. So just to bring out again something you said, but that because you mentioned TRLs, and that's a basket triglyceride-rich lipoproteins.
Yes.
But not all of them represent necessarily the same risk or metabolize the same way or different characteristics. You've spent a lot of time working with highly skilled colleagues like Tomas Vazar to have real high resolution understanding of the protein content, the lipid content, as well as the metabolism. So the C3 content seems to define a certain subclass, right? And so maybe you can discuss a little bit on why you think the TRLs with C3 on them have different pathways of both production and clearance and uptake by tissues.
Yeah, I think this is a very interesting topic, and the way we analyze the different triglyceride-rich lipoproteins is by using a method called differential ion mobility analysis. In human samples, we see that people who have similar triglyceride levels can have very different profiles in their TRL particle populations, so that some people have large numbers of the smallest, what are called remnant lipoprotein particles derived from these TRLs, and some people have a lot more of the larger TRLs. It was originally sort of thought that the smaller remnants of the TRLs might be more atherogenic because they might go more easily into the arterial wall. But actually, several data now suggest that maybe that's not the case, and maybe that the larger particles could be more atherogenic potentially. And those are the particles that are associated with ApoC, or there's more ApoC3 on those larger particles. So that's an area I think that is very exciting right now, to really map out some populations of TRLs and what if they have structural or functional differences and how they associate with cardiovascular disease risk in people with diabetes.
You can envision these particles not only representing a functional contribution, but maybe the often holy grail, a biomarker as well, so that depending on the analytical method, if it can be scaled up for clinical assays, could be used to differentiate or stratify people, right?
Yes, I think that will be
and then another indication, so I mentioned before how that paper based on the human experiment of nature, the C3 mutations, was very catalytic, and this one way to see, from my point of view, to infer that people are really starting to take this seriously is that when pharmaceutical companies start to invest in targeting a factor for therapeutic purposes. So maybe we can spend a few minutes, if you can just summarize what the clinical studies are on ApoC3.
There are different silencing methods to silence ApoC3. There is an liver-targeted antisense oligonucleotide, and there is an siRNA. And the antisense has been approved for lowering of extremely high triglycerides to prevent pancreatitis. But we don't know yet whether or not silencing ApoC3 would actually prevent cardiovascular events. And
But
so
those trials are in progress, though, aren't they?
they are being talked about,
Okay.
but they're not yet started. And I think design of those trials would be very important. And so hopefully we will have such trials in the future.
Yeah, unfortunately, they're outcome trials typically, and it'll take years from when they even start.
Yeah.
But I think the motivation is there. So yeah, one of the reasons why triglycerides, without having this higher resolution view that the type of research you do have given great insights, is that not only fibrates, but also niacin, which was used to lower triglyceride levels, a standard agent for years. And it was thought that niacin had a double benefit. It not only lowered triglycerides, but would raise HDL a little bit, lower LDL a little bit. But that the niacin studies didn't pan out. The fibrate studies have had a checkered history. And fish oils also lower triglycerides. They're used in everyday preventive cardiology. And even though there was a positive trial, particularly for EPA, the REDUCE-IT trial, that the detailed analysis of that trial was that the benefit was independent of the triglyceride lowering levels. So just because other agents have lowered triglyceride levels has not, we'll say, translated into cardiovascular benefit. So why do you think that is, that has been, and why going forward would we be more optimistic?
Well, I think therapies like ApoC3 silencing have the potential to lower triglycerides to even lower levels. And the hope is that maybe we can also lower total ApoB levels, because total ApoB levels, which includes LDL, of course, are probably a good predictor of CVD risk. And so I think we need more research into exactly which TRL-rich particles are the atherogenic ones, and if we can target those, that might.
So is there information? That's good. So have you gotten plasma samples from, say, the fibrate trials to see if there's been differential effects on these subclasses?
So we haven't done that, but that would be very interesting to do that.
That would be, I think, very informative. Whatever the answer is, it's interesting.
Yes.
All right.
Great.
Again, to emphasize again for the audience, and but also was clear from your talk, is that not all triglyceride-rich lipoproteins are the same, and these can have functional consequences, and certainly in the mouse models they do.
Yeah.
And I know you've been doing, like you say, was it human first? Wait, what was the phrase?
Human first.
Human first. That you've been analyzing a lot of samples from clinical studies, and I think the accumulating research just makes it a stronger and stronger case that some subclasses of TRLs are not so good for you, right?
I believe so.
Right. I certainly have enjoyed talking to Dr. Bornfeldt, and hope the subsequent meetings of this type will hear more and more great stuff.
Thank you so much.